I'm ready when you are.
Good afternoon. I am Katie Morell. I'm with Neurelis Pharmaceuticals in marketing development, and I get the distinct pleasure of introducing Dr. Kate Labiner. Had the opportunity to hear her present last year and earlier this morning, and you guys are in for a really big treat. She is a child neurologist out of Child Neurology of Austin. And without further ado, Dr. Kate Labiner.
All right, so this year I'm going to be speaking about immunotherapy and the treatment of epilepsy. This is more of an up-and-coming field, but also one of the oldest fields that we know. And that, I think, is what I find so fascinating about this. We have long been using steroids, and now we have so many more options, and we're learning that for very specific conditions, it can be very, very helpful. So we'll go through kind of the start of all the different things that are involved. So when we're talking about epilepsy, we're not just talking about one thing. It starts with the emergence of the dysfunction, right? That's the seizure. That's what we're seeing. But what's involved in this is really complicated. It's not only the networks, but then also the cells themselves, the cellular process that each cell is going through, the molecular processes, and then you get down to the genetic factors involved as well. And so at every single step, there's a chance for something to be wrong and for there to be dysfunction. Each of the different types of treatments are really targeting different areas. When we talk about the anticonvulsants, which are the classic version of how we treat epilepsies, right? They're really just targeting right here. They're targeting the molecular changes. How is each cell running itself? And now what we've learned is that sometimes it's really not just that one process, but a really big picture that's the problem. Just another way to look at it is look at all the different types of epilepsies we have. And I really like this part at the top because it's all the different things that can go wrong. It's the DNA, it's the infections, it's the brain itself, it's how the system's running. If you have a tumor, that changes everything too. You'll see a lot of these slides are tumor related, and that's because that's where immunotherapy started, was in cancer. We use the same theory and the same treatment ideas, knowing that it's targeting the cells and how the cells are working. And so what they saw when they were doing treatment in cancer was not just that the cancer cells themselves were being attacked, but that also was reducing inflammation and helping the overall system in that specific organ that was targeted then improve its function and then also improve the treatment. We tend to think about all of this as linear, and it really, really, really isn't. Drug-resistant epilepsies are a subset of all of the other epilepsy types. So you have all these different mechanisms that can be targeted, right? We have the target hypothesis, which is basically that we can pinpoint one thing to make everything better. Right? And that was really where the medications first started. What could we do? Can we increase the inhibition? Can we decrease the excitation? And that's the idea behind all of the medications. But what we found was that, gosh, we really have other things going on. You have neuroinflammation. You can imagine, right? If you use your hand a bunch in one day, what happens? It gets sore. If you have a neuron that's seizing all day long, what do you think that neuron's doing? It's sore, it is tired, it's going to be swollen. So we know that there's more to it than just, yes, it's being used and it's firing all the time. There's a lot more involved. You also have genes involved, right? So we all of the medications work under an assumption that those molecules are the right ones. We're targeting normal areas, right? But what's wrong in epilepsy? Well, those neurons aren't normal. They're not doing what they're supposed to be doing. So there's got to be different ways to target these things. And that's why we think sometimes the traditional anticonvulsants don't work. That's also, too, the issue when we talk about very specific conditions, especially some of the genetic conditions. We know that there are people who say like, oh, well, you shouldn't use this type of medication for certain genetic conditions, Dravet being the one that's probably the most common. And we talk about, oh, right, you're not supposed to use the phenytoins of the world. Well, the reality is that we know that those work when you are in status. Well, why would that be? right? But that's because I think we don't have a really good understanding of exactly what those molecules are doing. And I think the ketogenic diet is another beautiful example of this, right? We know it works. It is actually one of the oldest referenced treatments. They referenced it. The Greeks talked about fasting and curing epilepsy. It's referenced in the Bible. A man with fits went to the mountains for 2 weeks and fasted and came back cured, right? That's the ketogenic diet until proven otherwise in my mind. And so we know that there's something else going on. Why does it work? Great question. We know it changes the way that the cells are working. It's changing your metabolism, but we don't actually know exactly why it works. When we talk about immunity, there's two big parts of immunity, right? You have your innate immunity, and then you have your adaptive immunity. And this is true in every single organ system, but especially in the brain, right? And each one of these are going to change the way that your neuronal pathways are working, your neuronal ion channels, and then enhancement of the way that the synapses of the nerves themselves are talking to each other. And this is the idea behind immunotherapy, is can you target the aspects of your immunity that isn't working or is working? Because sometimes I think we always think of it as, oh, it must be working too well, but sometimes it's really that it's not working well enough in the right area. So picking the right one is also going to be so important. We talk about antibody-mediated encephalitis, and this is going to be where a lot of the research is done. And when we talk about the use of immunotherapy in very specific epilepsies, you'll see a lot of them are in autoimmune encephalitis and the autoimmune-related epilepsies. And the reason for that is because it's very, very clear that immunotherapy should be working, right? These are kids whose immune systems are amped up, and it's attacking itself. And that's really what we're targeting then in those specific cases. But there are other times where we don't have a specific antibody, we don't know exactly what's going on, but yet we know steroids and IVIG have been shown to work. And the biggest example was actually the talk that came before me, and that was on ESUS. And there's a lot of evidence to say that immunotherapy works in ESUS, but yet we don't know why that is true, but yet there's a lot of data to support. When we look at epilepsies and kind of how we work through epilepsies, there's this whole scoring system for the autoimmune epilepsies. And what you'll see is that as you keep going through, we have this specific antibody. Oh, no, we don't have a specific antibody. You still end up with a handful of kids who are probable, because we don't actually know, because we're not that good yet. We're getting there, but we're not as good. And I use genetics as a beautiful example of this as well. When I started my training, which was not that long ago, we had on an average epilepsy gene panel, we had 180 genes. We now run 306. And so in 5 years, we essentially doubled what we could do. The same is true with the autoimmune testing. When it started, you used to get 1 page back, and that was it. And it was just negative for these 15 things. We are now running more and more and more because we know more and more and more that we didn't know before. So what is immunotherapies? These are substances that are either made by your body or in a lab that will either boost or suppress the immune system. I think that's the key, is that not only sometimes are we trying to improve your own immunity, but sometimes we're actually trying to suppress your immune system because things have gotten a little bit out of control. I like to say it got overexcited. So the treatments of the disease are then targeted at activating or suppressing the immune system. There are different types of therapies because you have the activation immunotherapies, and those are going to be your pump priming. Vaccination is a really common version of that. Then there are T-cell adoptive transfers, and then also checkpoint inhibitors. We're going to go through these and kind of give examples of what each one of those is. Then there's also suppression immunotherapies. These are the ones that most of us have heard of. Glucocorticoids being the #1 example of that. If you think about what happens when you have an asthma attack and you're inside and your lungs are all swollen, what do? We give you steroids, right? Why does it work? Because we're suppressing that immune response. Cytotactics, that's very, very commonly used in cancer treatment. You'll hear a lot about that. Antibodies, that would be IVIG, and then also drugs that act on your immunophilins. So that's actually targeting your immune system to suppress the production of more antibodies. Monoclonal antibodies and your checkpoint inhibitors are actually very similar. It's considered targeted therapy for both of them. Your antibodies are going to be made in a laboratory typically, and they are meant to boost the body's natural antibodies or to act as the antibodies themselves. So sometimes what we're actually giving you is antibodies from either other people, and we'll talk about that with IVIG, or we're giving you synthetic antibodies. We can also then put in the primers, so those immunophilins, to increase your own activity to kind of boost up the immune system where it's failing. Checkpoint inhibitors are going to stop cells from blocking the immune system. So these are when you are actually blocking your own immunity because there's been dysfunction of other cells. So these checkpoint inhibitors basically stop that. This is going to be common in a lot of the genetic epilepsies. We know, and again, cancer being the number one, you have the overgrowth and the undergrowth. Well, sometimes they're actually stopping the cells from checking themselves, right? And that's why you get overgrowth of certain cell types. And this is the idea behind the checkpoint inhibitors. You have the non-specific immunotherapies. Cytokines are proteins that are going to send messages between the cells to activate your immune system. You have the interferons and the interleukins, and they're kind of working in different ways. The interferons are going to be the proteins that alert your body there's a pathogen. This is the one that's like, something is wrong over here and we need to know what that is. And then it's typically going to be viral, but we actually use this to our advantage as well. Interleukins are going to be the proteins that are passing messages between the cells. So the interleukins are the one that's like, hey, that cell over there saw something that was wrong and we need to figure out what's going on, because maybe that cell can't function anymore to tell us what's wrong. What can the other ones around it do? Targeted T cell therapy is going to target the specific immune cells that are fighting infection. Lab-made T cells have added protein receptors to the cells that then allow the T cells to target a specific body. When we're talking about bodies, we're talking about receptor bodies and then very specific antibodies. So they are targeting very specific cells at that point, or very specific parts of your cells. Very, very common in a lot of our other neuro diseases like MS and things like that. The oncolytic virus therapies are viruses that have been genetically modified and then copied to release proteins or trigger the immune system to target a very specific place. So the common thing that you'll hear about this, and actually I think the most recent one in neurology, has been some of the spinal muscular atrophy treatments where they're actually using virus tags that we can inject, and then we use the advantage of the virus to then go and alert the immune system that something's not right here, and then use your own immune system to target part of the system. There's a lot of discussion about immunotherapy versus chemotherapy, and I think kind of knowing the difference between the two can be quite helpful. Now, obviously this is using cancer cells, but we use both of these treatments, right? When we talk about cancer treatment, and then also in epilepsy, we use immunotherapy and chemotherapy. And we frequently will use, for people who need long-term suppression of their own immune system in the autoimmune epilepsies, we're going to use that very, very heavily. So traditional treatments are really targeting cells with either drugs. Obviously, we don't use radiation in epilepsy. This is an example from cancer treatment. Versus the immunotherapies, which are then targeting really the ones that seem to be dysfunctional the most. So you have better protection of the healthy cells, which then also helps to reduce your side effect profiles. Steroids come in two really big forms. When we talk about corticosteroids, those are going to be the most common ones. Those are your glucocorticoids. Those are your immunosuppressants. Your mineralocorticoids are also important to us, and this is important when we are using your corticosteroids and your glucocorticoids, because those are regulating your blood pressure through your electrolyte balances. So frequently when you're getting steroid infusions, you often are we're making sure that you're getting all your salts too, because we know that the glucocorticoids are affecting your body's own ability to produce mineralocorticoids too. The sex steroids are also ones that we talk about in epilepsy. We know that hormones are very, very intimately linked with all of our problems in epilepsy, but let me tell you, I have a bunch of teenagers, both girls and boys, who we absolutely know that puberty has been a problem. Girls, obviously, it's a much more obvious thing. We can track catamenial epilepsy. You can't track catamenial epilepsy in boys because they obviously don't have menstrual cycles, but yet we know that those hormone swings are still happening. It doesn't stop existing just because you're male versus female. You also have neurosteroids. DHEA is the most common one that we talk about, and you'll hear a lot of us recommending that you go on high-dose omega-3 supplementation. The reason that we're recommending those DHAs, the DHEAs, omega-3 supplementation is to target some of those neurosteroids. Steroids are often also functioning in multiple different fashions. They're doing your signaling between molecules, they're decreasing your membrane fluidity, and then also they are highly concentrating your energy stores. By having all of that action in one place, especially an area that is very metabolically active like the brain, we're really hitting this in multiple different ways. IVIG is a mixture of normal human antibodies. I do think it's important for people to realize that when we're talking about IVIG, it may not be coming from one person. So when we talk about red blood cells and we give plasma or red blood cells, typically those are all harvested from one person. To get an adequate dose of IVIG, you may be mixing as many as 60 to 100 people together when they've donated antibodies. And I do think that that's really important. Now, somebody with a really good immune system may be able to donate enough. Especially for kids, I'm a pediatric neurologist, so some of our kids are getting small enough doses that they may be getting it from just one person, but a majority of the time it's actually a pooled bunch of antibodies that then gets divided up and given out. Now, the one bummer thing for most patients is that these are really only given with injections of some sort, either intramuscular, intravascular, or subcutaneous. A majority of what we're doing in epilepsy is going to be the intravascular. We're doing timed different types of therapies as opposed to really kind of timing them out usually in the 4 to 6 week range, depending on which one you're using. For some of the chemotherapy agents, then we can use the intramuscular versions, but that's much less common. We know that these are working multifactorially. There is no one way that immunotherapy is working for you because it's binding to your antigen presenting cells. So these are the cells that are like, hey, there's a problem over here, I need help, right? It's also increasing your inhibitory receptors. So we know it's changing the way that the cells are talking to each other, and it also shortens the half-life of your autoreactive antibodies. That's huge, and that's often what we're really targeting, because what we do is we've given your body extra antibodies. We've now told your body, you don't have to make so many right now. We've got this covered, right? So you've essentially hit the reset button on your computer. You push that power button, held it for a hot second, and then you let it go back on. Right? That's what we've done for the immune system with IVIG. We have literally pushed the reset button for your immune system. And the thought is that if we can do that and keep you from making the antibodies that aren't working right for you, that can be helpful. Also, too, we've taken them from people that we know have good immune systems, right? Theoretically not dysfunctional immune systems. So they're also going to bind to some of those cells for you to keep them from doing things we don't want them to do. They're targeting a bunch of different aspects with immunotherapy too. Not just the antibodies themselves, but also the T cells, right? So those are the ones that are helping you fight things yourself. You're also targeting cytokines. That's going to be the release of things for your own body too, right? So all of these areas are getting targeted in all the different aspects of our immunity. The classic study for immunotherapy is the UKIS trial. This is one of the first really big immunotherapy studies that was done, and this was for children with infantile spasms. So it stands for the United Kingdom Infantile Spasms Study, I think. And so they were randomly assigned to hormonal treatment with prednisone, mostly prednisone, or vigabatrin, which is one of our kind of classic AEDs. And they were looking at cessation of spasms, and it was more likely in infants who were given hormonal treatment than those who were given vigabatrin. And when we looked at their adaptive behavioral abilities, 14 months of age, it was higher in those that were given hormone therapy than those that were given traditional AEDs. At 4 years of age, and this is the amazing thing about socialized medicine, guys, you can follow these kids for years, and at 4 years of age, they re-demonstrated that they had better development. So this is now both at 4 years of age, we can track not only your gross development, meaning walking, talking, sitting, doing all of that, but also your cognitive development, right? What's your speech like? Do you look like you're on age norm? And the answer was that we saw better development in patients, and I think this is the key. Patients without a clear etiology. Those are kids, we didn't know why they had infantile spasms. And so we didn't ever have a genetic answer for them or a structural answer. And so this is important in the kids with tuberous sclerosis, because that's going to be one of the number one reasons why we see infantile spasms. So important that when we don't know, it still worked. They've also looked at just immunomodulators in intractable epilepsy. Now, all of these are going to be small studies, so I'll put that caveat out there. None of them are very big. Part of that is because the patients who are willing to do some of these studies are going to be the ones who are kind of in that worst group. These are kids who aren't responding well to other medicines, or adults. These happen to be one in children. In the control group for this one, they had to have at least 2 anticonvulsants in combination. And when you looked at the numbers of what most people had failed in this, kids were failing all sorts of things. And the average was that they had already failed 5 different anticonvulsants by the time they got to this study. So we divided them into 82 kids, divided into the control versus the observation group. The observation groups were given IVIG, 400 mg per kilo per day, as standard dosing for 5 days over the course of treatment, with once monthly treatment then following for 3 months. And that's pretty standard for us. You're doing high dose IVIG based on weight, and then continuing it at least every month. 3 months is often our kind of measure, and you'll hear us talk about that for diet and other modifications. And the reason for that is we know that that's long enough for you to get neuromodulation without then, if you don't see any improvement, it's probably not going to help. And so that's an important one. And what they saw was that the kids in that group actually did better long term. They had improvement in their seizures and less hospitalization. Immunomodulatory and anti-inflammatory drugs have been used in a variety of epileptic disorders, and we know that this also works. This one was done in rats. There are lots of different types of epilepsy studies done in rats, and I think that the nice thing in this was that they used ones that actually were intentionally given seizures. So these were normal rats, and then we gave them meds and made them seize. And so these were essentially the thought process being that these are going to be your people, look similar to your people who don't have an etiology, right? The seizures came out of nowhere. We divided them into 7 groups in this study. You had the normal, non-treated, epileptic, non-treated. Again, you can't do that in people, right? Nobody's going to let you have epilepsy and not treat it. Epileptic and treated then with a variety of different immunomodulations. We then watched the EEG tracings and all of those. They were all put into status epilepticus, and then the inflammatory mediators were measured. And what they saw was that the seizures led to decreased inflammatory mediators compared to the control groups. So what that means is that clearly your brain is not happy when you are seizing. We know it's reacting poorly. I think anybody who's been around people with seizures knows that's happening, right? Why do we have a postictal phase? It's not because things went right back to normal. The treatment then helped to reduce the frequency and the amplitude of the EEG tracings. And that's where it's important in ESIS, is because we know that it can. It also then decreased the levels of the inflammatory mediators in the treated rats compared to the untreated rats. So just by treating them with immunomodulators, the brain then didn't have that inflammatory response from the seizure itself. And these also lowered further long-term compared to other therapies. Okay, this is a really busy slide. I'm going to try to sum it up best I can. So in this study, they did the induction of epilepsy, again, was done in rats, by lithium and pilocarpine. And these are 2 of the most common ones that we use to induce seizures. And what they showed was that the rats in the groups where the seizures were induced then had increase in a bunch of their different like interleukins, right? Remember we were talking about the interleukins and the interferons, right? So their interleukins, the way that the cells are talking to each other, were increased. And it was multiple of them that were increased, not just one. And this was when we compared it to the normal ones. When you treat them with celecoxib, which is like basically Aleve, but on a more medical side. So slightly more exciting Aleve. Then the induction of the epilepsy showed decreased production of your interleukin 6. So we proved that just by using an anti-inflammatory, you could potentially make things better. right? Their PGE2s and their serum interferon gammas were also better in comparison to rats who hadn't been treated. Then when you treated with methotrexate, which is kind of one of our classic immunomodulation therapies, you see methotrexate used a lot kind of across the board, very common in a lot of the rheumatologic conditions, a lot of the autoimmune treatments, very, very common. Again, we saw that compared to the epileptic non-treated rats, they again had decrease in multiple interleukins. So we know that this is helping. Azathioprine did the same thing, and so did dexamethasone. In the valproate treated rats, right, one of our classic treatments for epilepsy versus the non, you saw that the induction of epilepsy reduced it. However, it wasn't when you compared it to the others. So the immunotherapy worked better. Interleukin-1 has been very clearly, in some case reports, been shown to be related to epilepsy. We know that it has a large key to play when we've looked at animal models. It's a little bit harder, I think, for us to obviously translate that, but that's because most people don't really want us doing brain biopsies while they're seizing for us to know. But they were able to show that when we've had some people with other systemic inflammatory diseases and refractory epilepsy, so these are going to be people with lupus and epilepsy, or rheumatoid arthritis and epilepsy. Those are the people to kind of think about when you don't have a very, very clear genetic autoimmune or periodic fever syndrome. So, right, we don't know it's lupus. We don't know what it is, but we know that they have systemic inflammation. This kid had a normal MRI and then also showed generalized spike and wave on their EEG. They had persistent elevation in both in their S100 alarmin, which is the protein that is going and telling your body, like, be inflamed, be inflamed, be inflamed, because something is wrong. They had a prompt clinical response. So this is looking at clinical seizures with anakinra, which is one of our injectable immunotherapies, and then near complete resolution of clinical seizures when using one of the chemotherapy agents through IV. We know that encephalopathy with ESUS or CSWS has shown clear improvement with immunotherapy. This is probably some of our best data in non-autoimmune epilepsies. So there are 95 children in this study. The mean age at diagnosis was 5.5. The structural etiology in about 43% of them, a genetic etiology in less. However, interestingly enough, as we were talking about, right, it increased over the course of the study. Well, that happens because our genetic testing got better. It's not because we pulled in the right kids, quote unquote, right? It's just because the testing got better. You can imagine the difference between scanning for 100 genes versus 300 genes. You're going to find more when you're scanning for 300. Over 70% of them were considered refractory. And so this is refractory from both the ESUS standpoint and then clinical seizures. The average patient coming into the trial had already tried 5 different treatment strategies. Steroids and neurosurgery were shown to be the most effective. However, there was no difference between the CSWS and the CSWS. And I think that that can be really important because when we talk about ESUS, one of the big things, and I think even if you came in right at the end, right, one of the things we talk about, what's your spike index? What's your spike burden? What does that look like? But clinically, it's also really important to know what they look like because while we may not be able to fix the EEG, I do think the presenter before me made a very good point, and something that I always talk about with my patients. I'm treating a kid. I'm not treating a study. I have to treat the kid in front of me. And if the kid in front of me is now going to school and not having seizures, I don't actually really care what the EEG looks like, even if it still doesn't look 100%. We're looking for the combination of clinical improvement and also can I get the EEG to look better? But the EEG looking better is the secondary endpoint. When we talk about the changes and predicting who could do, who may be a good person, who may not be a good person for trying out autoimmune therapies, we can actually use neural specific antibody seropositivity. And so we're running a lot more autoimmune tests in our epilepsy patients. This was really something that was pushed, I think, a lot more on the adult side early on than it was on the ped side. We were really good at the genetic component and not as good at looking at autoimmune epilepsies. Well, part of that is because autoimmune conditions aren't as common in children. Much more common in adults. But what we saw is that if you had an APE2 score that was higher or equal to 7, it had a specificity of almost 100% for an autoimmune etiology of your epilepsy. That's huge, because now we have an actual measure of something that we can do to say, is it worth trying this therapy in a kid who we may not know why they have epilepsy? And the answer is potentially. This is a study that was done at Mayo Clinic, and so you had patients with epilepsy with an exclusive or predominant presentation, meaning that we know kind of why they have it. We think that these kids had autoimmune epilepsy to begin with, but we weren't 100% that was going to be true. And what we saw was when you added them to immunotherapy, I don't have a little, no, I just have a clicker, I don't have a pointer, I'm sorry. So what we saw was that immunotherapy plus AED therapy alone, again, had higher improvement, and a handful of these kids later on were found to actually have, as our autoimmune testing got better, were found to have autoimmune epilepsies. Kind of the most classic one, I think, that's come up in my time is the anti-NMDA receptor antibody encephalitis. We finally got a good test for that, so you'll hear about it. It's like been a thing for the last 10 years. It's been a thing a lot longer before that. We just didn't have a test to tell us it was a thing, and that's really where we've gotten. But I think the other important thing in looking at this is that quite a few of these kids were also negative, right? We never figured out what they had, but yet they still responded. When we talk about the inhibitors too, I think one of the big places that this has come is in our TSC patients, right? We know that these kids are prone to tumors, right? That's part of the reason they have tuberous sclerosis. They have a gene that is literally dysfunctional leading to tumors, right? This is going to be similar to our NF kids too. They've done a lot of use of immunotherapy in our TSC patients, specifically with everolimus. And they're now actually recommending trying everolimus even in the kids without SEGAs, which are the very specific tumor type we see in kids with TSC. It's an mTOR inhibitor, and it's shown both long-term benefit from a safety standpoint and then in the treatment of medically refractory epilepsies. Now, granted, this, of course, is only done in TSC patients because that's where it was targeted, but I think it's the start of us talking about, can there be other treatments? Because we knew that the kids with TSC without the specific tumor type that is targeted by everolimus seemed to get better, and they maintained that improvement despite continuing to have development of their TSC. So they may have gotten more tubers, they may not have developed a SEGA, and yet we still saw improvement in their epilepsy. There's also a lot of evidence for high-dose steroids. Steroids, again, like I talked about, one of the oldest treatments for epilepsy. And I had one of the guys who trained me who always said that no kid with a status epilepticus should ever leave a hospital without being given steroids, because he felt that really it was one of the easiest things you could do to prove, are they going to respond to immunotherapy? And I will say we use high-dose steroids now as a way to get IVIG approved, especially in our ESUS kids, because we can't prove an autoimmune condition in most of them. However, we can't get the IVIG approved because it's not a reason, quote unquote, courtesy of the insurance companies. So we use proof of steroids working to say, well, now this is why I need IVIG. So we know that in kids, these are kids aged 17 children, so again, small numbers, 88% of them were having daily seizures, 76% of them had been in status epilepticus. They were given regular steroids, and 35% of them became seizure-free. So these are kids who were not seizure-free before this, right? And then 59% had what we would define as seizure control. Okay? The other really important thing is that it was a mixed seizure type. So one of the most frequent things you'll hear when we talk about the classic anticonvulsants is like, oh, that one's really good for the spasms. That one's really good for the generalized convulsions. Oh, that one's good for the tonic seizures, right? We know that part. This was mixed seizure type. So we were taking all seizures, lumping them together. Did you get better, yes or no? And the answer was yes. In adults with new onset epilepsy, there's been a little bit more work now in immunotherapy. So these were taking people who did not have seizure as children. These are just adults, new onset epilepsy, right around 45 years of age, and then looking for autoimmune antibodies, but then also using, oh, I have a typo, 32, then also using the therapies for that. So what we saw was that patients who received immunotherapy, whether it was high-dose steroids, which is the most common, Plex, which is plasma exchange, this is when we put in large bore catheters, typically into the neck. At least in kids, we always put them into the neck. I don't know where they put them in adults. I assume the neck too. And what they do is we actually take your blood out, wash it, take out your antibodies, and put the rest of your blood volume back in. And then IVIG, rituximab, which is kind of a classic chemotherapy agent, as well as cyclophosphamide and mycophenolate. I will say in neurology, we tend to use more Rituxan than anything else. And what they saw was of those 34 patients, you had, 19 of the 34 patients had achieved a greater than 50% reduction in their seizures at their first clinic visit. Also, the time from symptom onset to diagnosis and then symptom onset to immunotherapy was significantly lower among patients who achieved a responder rate. So these are people who are now feeling better faster with new onset epilepsy. In children, we have a lot more of the short-term studies. So this was actually looking at kids coming into the hospital and looking at symptomatic relief using immunotherapy only. So they are looking at people who had had acute onset of their seizures within the last 3 months. Again, multiple seizures types. These kids are seizing at least 10 times a day, and that's a lot. Right? So they were all on treatment with 2 or more anticonvulsants, and that was not fixing the problem. They're still seizing 10 times a day with 2 or more anticonvulsants. And what they saw was that 8 patients with immunotherapy went free of recurrence of their seizures, and then 1 had significantly reduced seizure frequency. So all of them responded. It was just in different ways. 8 of them, very happy. 1, better, but not completely cured. In new onset refractory status epilepticus, or NORS, so you'll hear us talk a lot about NORS and fires. These are kind of 2 of the big presumed autoimmune epilepsies. So in fires, you have febrile induced. So these are kids who get a febrile infection of some kind. We don't always know what it is that triggered it, who then go into refractory status. And then NORS, which is the new onset refractory status epilepticus. So these are typically kids and adults. It's actually more common in older kids than in younger kids. Who are presenting with like sudden onset of status epilepticus, having never had a seizure before in their life. And so they usually kind of seize some more, and are typically from the start to when they end up in the hospital is usually a handful of days. In fires, it's a little bit longer. They can have as long as 2 weeks leading up to their hospitalization. None of the 40 patients in this study had positive neuronal antibody testing. So they were tested for antibodies. We did not find one. Their immunotherapy was used in half, and the long-term outcomes weren't dependent on why they had epilepsy. So we may have found a genetic cause after. We may have found a structural cause after. But what we saw was earlier intervention with immunotherapy, Plex, IVIG, and steroids, or a combination. Most people are getting a combination of those, was associated with shorter duration of status epilepticus and shorter admission. This is fires, like we were talking about. It's considered a subset of NORS. And so you have to have a febrile infection within 24 hours to 2 weeks prior to the onset of your status. We've actually shown that there are inflammatory changes in the CSF even when we don't have an infectious or autoimmune cause. So these kids are almost universally getting lumbar punctures because we're trying to look to see, can I prove what happened? Do they still have an active infection? Can I find an antibody? And if the answer is yes, then great, we know what we're treating. But we were seeing inflammatory changes even without that. That goes back to some of those earlier slides where we were talking about what are we seeing, what we know, right, in rats, that even when we were making them seize, they had increased inflammation, right, without a clear cause outside of we gave them a medicine to make them have a seizure. The report showed improvement with the use of high-dose steroids, IVIG, and plasma exchange. Anakinra, which is we have spoken about before, is an interleukin-1 receptor antagonist protein, and that has also been shown to be effective in the treatment for these children. We look at high-dose steroids versus IVIG. Prednisone is going to be the most common one that people are getting, and that in our genetic epilepsies, our lesional epilepsies, and then our unknown causes of epilepsy, we've actually shown that they can respond. So with prednisone alone, a 24% responder rate, 2 of those were genetic, 3 were unknown, and 1 was lesional. Lesional meaning that they have a structural cause to their epilepsy, whether it be a cortical dysplasia, an area of stroke, anything like that, where we can pinpoint, on your MRI, this is why you're having a seizure. And with a mean seizure reduction of 95%, and a mean time to their best response of 2.5 weeks. And that's important, I think, when we're talking about managing expectations too. Unlike with some of the other medications where we can give you an IV load and I can tell you within 48 hours if it's working or not, these are going to be long-term because, again, immunomodulating, right? We are changing the way your body is responding to things over that time period. When we use IVIG, the best response actually comes weeks, sometimes months into it. I typically tell parents, if we're giving you steroids, I don't expect to see anything until at least 3 days. And if I'm giving you IVIG, I'm thrilled if it happens really quickly, but honestly, I'm really looking a week to 2 weeks out. Have we started to respond? 84% responded for the IVIG patients with a seizure reduction of 77%. And again, their mean best response time was about 8.5 weeks. There's a lot of discussion of stem cell therapy. I think this is across the board. People are talking about stem cell therapy and what can it do, what it could be used for. It is not considered a classic therapy for anti-epilepsy, as a kind of used for any of that. The interesting thing is that there have been studies, not in this country, but in Europe and the Middle East, that have both shown that you can do intrathecal injections of autologous stem cells, and that can be seen as helpful. Plasma exchange is readily used. We actually did a study, and actually I referenced it earlier, was a study that I did when I was in my fellowship, looking at NORSE patients, so that's a new onset refractory status epilepticus, and using both Plex, IVIG, and then steroids. We use a lot of combination. The one thing about Plex to remember when you're using it is that if you're already giving IVIG, you don't want to do the Plex therapy, right? Because it washes out the antibodies, so the antibodies from other people we just gave you, if we then do the Plex, we just wash them right back out. So you'll often see Plex first with steroids and then IVIG. So you had refractory patients, obviously. They've typically tried multiple anticonvulsants. Most of them have been in a coma for at least 3 to 5 days at that point, because we are using medically induced comas as treatment. They have had extensive evaluation, MRIs, all sorts of radiology scans of all parts of their body looking for all different types. But what was shown is that you could get, with plasma exchange therapy, cessation of their status in day 4. Now this is a very, very, very small study, right? But the proof is that it can work in the right patient. And I think sometimes we look for like the perfect patient and not just who could it potentially work in. And that is what I got. Questions?
Hey, you said stem cell therapy intrathecal versus that intro whatever?
Yeah, so they're actually, in that case, going to do a lumbar puncture and then inject the stem cells into your spinal fluid. Yes, that is intrathecal, as opposed to intramuscular or intravenous. Yes?
So what is the side effect profile for this versus standard AEDs?
So that's the interesting thing. IVIG, I will say, on the whole, pretty well tolerated. It does take more blood testing before we start you on it, because what we do have to make sure before you're doing IVIG, Rituxan, mycophenolate, any of the kind of traditional chemotherapy agents, is that we aren't going to open you up to other issues. And so you'll see a lot of, like for an MS, for example, we have to check for a very specific virus. If you've been exposed to the JC virus before and we give you certain immunotherapies, we can actually then create our own problem that we didn't mean to in the brain, where you get the periventricular leukomalacia, or death of the brain right around the ventricles. That can happen. It's very, very, very rare, but that is one of the things that we always look for, especially here in Texas, not here, but in Texas where I practice. We test all the kids for TB beforehand, because if you have dormant TB, we can actually reactivate it unintentionally, because typically your body is suppressing the TB. I will say most of the time steroids have the highest of any of the side effects. Kids are angry, they're hungry, they're angry and hungry. They want to, and this mother knows that I use her quote all the time because I thought it was so funny. Her kid had infantile spasms, and she asked me, is my kid going to deflate afterwards? And I said, oh yeah, they will. And it's because they get super swollen from the steroids. And so they get these really big facies. And the kids are uncomfortable because they swell so quickly. IVIG, much less. Obviously, plasma exchange in itself has no side effects except for your risk for infection. But yeah, you have to have these large bore catheters for kids because of their blood volume. We actually have to space it out by days. So if you're doing you do 5 rounds. And the standard is anywhere from 5 to 7 rounds of plasma exchange. Then that's 10 to 14 days in a hospital with gigantic things in your neck. For the older kids, we can actually keep them awake and do it. But the younger kids, you end up having to sedate them because we can't have them messing with so that's a huge barrier to using plasma exchange.
Nobody else has.
Hit me with it.
So I know obviously in the studies and the kids that you're working with, seizure control is the top priority, right? If they do not already have that. But one of the challenges of being a parent is the burden itself of the anti-epileptic drugs. So with the addition of immunotherapy, are you seeing a reduction in the need for their other medications, and then some of hopefully other benefits, so changes in cognition or behavior or things such as that?
Yeah, and I think that, again, ESIS and infantile spasms are the place where that comes into play the most in terms of kind of the advantages we have from a study standpoint, and then also from just a what do we see the most of standpoint. And the answer is yes. We have kids, especially steroids, now it used to be that ACTH was kind of considered the classic, oh, this is what you try if a kid has infantile spasms, and it's really shifted after the UKIS trial and said, well, we should be doing prednisone. Then in this country, the cost of ACTH became so astronomical that steroids really became preferred from a cost standpoint, but we also know that there are kids who never have to go on an anticonvulsant. If we can fix it with steroids, you're done. That's it. And so, that's huge. We also see that we can reduce it, especially in ESIS. I have many kids who have come to me on multiple medications, and we're able to just start getting them off of it. And so as you can come off of it, coming in once a month for an infusion, I get, is hard. It's not fun. The kids don't like it. I completely understand that, but a lot of them like it more than they like taking meds twice a day, every day. And if the meds aren't working, then they're taking something that's not working, usually with side effects.
Have you considered it in children who do have seizure control within a relatively high medication burden?
You'll see steroids used in those cases. The problem is that steroids are really a temporary kind of solution, right? That we don't really want kids on long-term high-dose steroids, so you end up having to use then the lower doses of the steroids to kind of help with that. But it's a complicated one because when you're on high doses, what do you do? But we know it can help with steroids. IVIG very rarely going to be used, and the biggest barrier we have to it, truthfully, is payment. Insurance companies are not going to want to pay for it if I haven't proven that it's going to work because it's expensive. So each round of IVIG is anywhere in the $1,200 to $2,600, and you're doing that every month. And so we have to know that they want to know it's going to work before I do it.
I mean, that's comparable with the cost of
Oh, yeah.
when you get into
Yep.
the higher tier drugs.
Oh, for sure. Yeah, I mean, if you're looking, right, that's going to be very similar to your cost for Epidiolex if you're paying for that out of pocket. For example, I looked the other day what a Copri cost, and it's not cheap either. I mean, even some of the ones that we don't think of as being terribly expensive, right? If you take brand name Onfi, that's $650 a month. That's a lot of money. And so is it worth trying it? I don't see why not. No. And especially too, if you've met your deductible, try it. This is my favorite time of year to try things.
Do you recommend staying on the IVIG cocktail that we're on, and just wondering, like, gosh, I would love to see us decrease on that.
I usually say if you've hit that 3-month mark and things are still stable, that's when you start talking about decreasing things. Yeah. I use kind of 3 months as the big marker because that's when we know, right, at that, the slide where I was saying that at that 9.8 weeks, right? If you've hit 3 months, that's 12 weeks. That makes us feel pretty good that it's helping. But I have some kids that if we know it's not working, we just start taking them off of it. I don't like when my kids are on more than 3 drugs. 4 is about my limit, just because I feel like at that point we're just adding without getting clear improvement. So at the most, I want to try to get you off of it, because at least then if we can take a lower dose, even if it's more, I'd rather be on less than more.
What do you think about this new stem cell therapy directly into the brain cells?
I'm not gonna lie, I don't know a lot about it, and I think that much like a lot of the stem cell therapies, we probably don't know enough yet. And part of the issue too is that, again, anytime you're injecting anything into the brain, that always makes us real nervous. But much with the stem cells and kind of why a stem cell for a lot of the neuro conditions is not one of the things that we have good efficacy for, is because each of the neurons are so very targeted in what they do that after the brain has now developed completely, we're now trying to put cells in there and be like, oh, by the way, I need you to be this exact type of neuron because that's the area that's not functioning right. And that's what's hard. I mean, I don't think we have a good understanding of all the nuances of that to be able to say, like, yes, we can do this with good efficacy. And so right now, I think we're kind of in that, is the risk worth the reward? And I think the reward right now is really unknown and the risk is really high. Yes, Gary.
What about the hyperbaric oxygen?
So in terms of just from an immunomodulation standpoint, we know absolutely that it's anti-inflammatory. In terms of epilepsy, we haven't done a lot of research. There is evidence in a lot of like the TBI, the traumatic injuries, and they use a lot of combination of hyperbaric and then also cooling therapy for that. Yeah, and actually that's the classic treatment for babies, right? If a baby has a big insult at birth, that's actually what we do. We cool them. Thanks, everyone.